Yes, Robert.
Hello, dear RIWOspine Alliance members, and welcome to today's webcast. My name is Robert Bajura, and our topic today is dedicated to the foraminal bone resection in the transforaminal. We are very glad to have with us Dr. Ali Güven-Yurukoglu, our well-esteemed clinical manager, neurosurgeon, and endoscopic spine expert. He will start with a small presentation on the topic, showing you all different options that we have when it comes to foraminal bone resection, which includes foraminal resection under radiologic control, as well as under full endoscopic vision, with many tips and tricks for you for your practice. This short presentation will be followed by a live demonstration on a very realistic real spine model that you know from our other webcasts. So, as usual, you will be allowed to post your questions in the YouTube chat function, and Dr. Güven will reply to them immediately. And this will be followed by a last part, by a discussion after the demonstration, where we can reply to your other questions that you have. Feel free, as always, to send us your remarks and other questions to education@riwospine.com. So thank you for watching, and I wish you an interesting webcast.
Okay. Okay. Welcome everyone from my side, from the headquarters of RIWOspine and Richard Wolf from Germany. Here today, as Robert told you, we prepared you focused, detailed program on the bone resection with the technical possibilities of bone resection with the transforaminal approach. In this topic, I would like to introduce you both technique. First, the manual radiological control system, as known as a foraminoplasty or foraminectomy in the literature, and the most preference from our side is the tip control and full endoscopic bone resection under visual control. Let's start with a small presentation. Okay, as you know, we have the two standard approaches. If you use the foramen, we call it foraminal approach, and well-known name for this is a transforaminal. And also the second approach is the interlaminar approach if you use the spaces between two laminas. Which approach selection? Always this is a big question, and depends on the surgeon experience a little bit. In this case, we would like to share our experience with you. Of course, if you search the literature and attend the symposiums or clinics, you can find a different opinion about this. That's why we can only share our experience with you, and we have experience more than 25 years with the thousands and thousands cases with all our users in all over the world. What we prefer to do, what we find more practical in the daily practice. First of all, of course, as we know, the foramen is really open gate to the spine. We would like to use this, yeah, but in our experience, we have some limitations to do that. First of all, we check the iliac crest position. If the iliac crest is higher than the upper pedicle in the level, means that if the foramen is overlaid by the iliac crest, then we prefer to do it interlaminar approach. Okay, the second criteria for us, the migration of the disc herniation. As you see here in the green zone, it's really easy to reach the fragments, but in the red zones, it is possible, and the topic of today could be this, and but it's not very practical. That's why in the green zone, we prefer to do, according to the fragment, we prefer to do transforaminal approach. In the red zones, we prefer, if the fragments are in the red zones, then we prefer to do it interlaminar approach, which we find much more easy and the practical. And the third criteria for us is the foraminal laminotomy. Of course, in this case, we can discuss the topic of the foraminal bone resection, but actually my experience and our experience as a RIWOspine, doing a lot in the foramen always has a risk to do to do complications. That's why if the foramen, especially the caudal side of the foramen is narrow, then again we prefer to do it interlaminar approach. And the second thing about this, reason for this, what caused the narrow foramen? Hypertrophic facet. And if the facet joint is hypertrophic, then it means that, in my opinion, there is a compression on the traversing nerve root at the same time. And to decompress the traversing nerve root, it's not easy to do it with the transforaminal approach sufficiently. Then it's really better to do it with the interlaminar approach. Okay, we have three types of transforaminal approach. Basically, the first one is known as a posterolateral approach, which is described in the literature, I think in the late 75 or like that. The working angle with this approach is around 45 degrees. It's really easy to reach the interdiscal space, but the problem here is reaching the ventral epidural space. Then why? Because there is a facet joint there. While you are introducing your dilator and the sleeve and the instruments, this SAP, the facet joint, will push your instruments into the disc. And to reach the ventral epidural space, then you need to do bone resection. Okay. And not to have any problem with this, usually we prefer to choose more lateral entry, known as a lateral transforaminal approach described by Dr. Rutten. And with this approach, without having any problem, you can with the facet joint, you can easily reach the ventral epidural space. And the third approach is the extraforaminal approach. Basically, if you are working outside of the foramen, this is called extraforaminal approach. Let's come to the topic for the bone resection. If you want to do the bone resection with the transforaminal approach, now we have two options in our hands. The first option, you can do it under fluoroscopic control with the manual drills. And the second option is the full-endoscopic visual control with a tip control shaver. What is the radiological control? Maybe you know this. The well-known name is the foraminoplasty or foraminectomy. You can introduce your needle to the bone, or you can duct on the bone or on the dorsal annulus, according to your preference or what you want to do. Then you can introduce the guide wire through the needle. And over the guide wire, you can dilate with the step dilators. And over the dilators, you can place the working sleeves according to the size. And then after that, you can do the manual drilling under the fluoroscopy control with the drills. There are different options here. First option is the lateral cutting burrs, and the second options are the front cutting burrs. I will come on this topic later. And another option for us, which I prefer in my daily practice, the tip control shavers. Today I'm going to demonstrate this on the model. What is it? We have a shaver, and there's a button at the back side, and you see on the model demonstration, when you press the button, the tip is deflected, then you can easily reach the bony structures during the transforaminal approach without changing the direction of the system, because most of the complications during the transforaminal approach occurs by changing the direction of the sleeve and the system. With this, you can easily squeeze the exiting nerve root, or you can hit the ganglion, and most of the complications are occur that. And really, it's important to reach the bony structures without changing the direction of the system. Okay, let's come to the demonstration. First of all, I would like to introduce the foraminal bone resections to you, the instruments I mean. We have a foraminectomy, vertebralis foraminectomy set, which includes the lateral cutting burrs here, and the step dilators and the sleeves. All they are coded with the color codes. And the green one is the smallest one, blue, and the red one is the largest one. There are two possibility. First of all, if you want to dug on the bone, you can come with the needle or with the jamshed needle. You can dug on the facet joint or the bone, then guide wire, and then you can start with the front cutting burrs like that. And after that, when you burr it, then you can continue with the lateral cutting ones, which the tips are blind. There is no risk to hit the neural structures with the front cutting burrs in this type of burrs. Then after that, you can place the final sleeve here, and then you can start with the endoscopy. But as we talk, the second option is you can dug on the annulus like that, and you can start directly with the lateral cutting burrs, and you can enlarge the caudal side of the foramen. As we talked before, we do this only to get better access to the spinal canal. It doesn't mean that you can decompress the recess with this, it's not easy with the manual drills to decompress the exiting nerve root, because the exiting nerve root is located in the cranial side, and you can only use the manual burrs in the caudal side of the foramen. You will see, of course, the large foraminal anatomy when you take a image after the operation, like a CT or MRI. You will see that the foramen is large, but it doesn't mean that you can decompress the exiting nerve root or traversing nerve root. Again, it is just to have a better access to the spinal canal. Of course, you can do this procedure even the manual drilling or full-endoscopic drilling. You can do these kind of operations under local anesthesia, or with the sedation, or with the general anesthesia. Okay, let's start with the demonstration. Every time as we talk, we prefer to do lateral transforaminal approach. And the steps of the lateral transforaminal approach starts with the drawing the lines, the entry point for the entry point. First of all, we start with the lateral control. In the lateral control, we draw the first line at just back of the posterior of the facet joint. This is the red line that you shouldn't exit to the ventral, otherwise you can easily penetrate to the abdominal structures. The second line is, for us, is the green line, is the posterior tips of the spinal process. Then you can choose your entry point between those two lines, but not more than the red lines that you can easily penetrate to the abdominal structure. Then when we draw the lines, then we switch to the AP control. In the AP control, you have to correct your angle. Yeah, means that you have to see the end plates parallel. Here already we see them parallel to each other. Okay, then we mark the middle of this space, and the cross sections of those two lines is our entry point. As I told you, you can choose your entry point according to your pathology. If it is more central, or if you want to do extraforaminal approach, it's better to choose maximum laterally, but otherwise for the paramedian herniations or pathologies, you can choose the green line or between those two lines. Okay, the next step is the incision, and before we do the incision, 0.5 centimeter incision usually is enough. Then we continue with the needle placement. Okay, what is the ideal position of the needle here? In the AP control, it is in the AP control, we want to be on the medial pedicle line. In the lateral control, we would like to be in the dorsal annulus at the same time. Okay, it's like that. I can feel some resistance here. I'm on the annulus at the medial pedicle line. I have the guide wire. Okay, again, let's talk about the needle placement, because the needle placement is really important here. To do bone resection or to do extraforaminal approach, we have to be careful a little bit about the foraminal anatomy. First of all, you can do this maneuver approach, passing through the cambium triangle, only if you see a free space at the caudal side of the foramen. Then the next, you can pull back the system out and you can start the operation. But if you don't see any space at the caudal side of the foramen, or if it is really narrow, then you can start like that. You can duck your needle at the caudal junction pedicle to the ascending facet, like that. I can feel the bone here. Then this is the safest way to start the operation. Yeah. Again, if you see a free space at the caudal side, then you can do the regular transforaminal approach and pull back the system a little bit outside of the foramen. Or if you don't see any space due to the fragment or something like that, you have to start at the caudal side of the foramen from this junction pedicle to do ACP. But in this case, I would prefer to do it with the regular transforaminal approach. And then we remove the membrane and insert the guide wire. We keep the guide wire there. Sorry?
Excuse me, Güven. Just one question. For example, if what do I do if I go for the extraforaminal case? So you said that in the case of extraforaminal, I need to go more caudal, yes? So if I go on the caudal side, so on the caudal pedicle, how is there any fixation method, anything I can do? Because otherwise everything will be loose.
Yeah, okay, just repeat again. To do extra, if the question is approaching to the extraforaminal herniations, not the stenosis, then we have two options. We have to check the preoperative images. First of all, we have to evaluate where the exiting nerve root is, and also do we have enough space at the caudal side. If we see enough space, then you can do like that. You can duck on the annulus. You can start at the medial pedicle line and the annulus, and at the end, you can pull the system back and rotate to the cranial side. But of course, if you don't see any free space due to the herniations or something like that, then you have to start like this from the bone. But of course, the option here is to fix it to the bone with the hammer a little bit. With the you can place the needle on the bone with the hammer. Then by this way you can keep the guide wire inside the bone, and you can introduce the dilator and the sleeve and start the operations directly like here. But in this case, you are right, everything will be free. You will not stack in the foramen with the sleeve, and then you have to control everything. That's why we never recommend to the surgeons to start directly with this kind of operations, pure extraforaminal operations. Yeah, and then
okay.
Is this the question, Robert?
Yes,
okay.
Yeah, that's it. Thank you.
Okay, then the next step, I keep the guide wire inside and remove the needle. Then the next step is dilator. And when we fix the dilator into the foramen, then we go with the sleeve. But for this RIWOspine model, the tracking device is fixed to the dilator. If I introduce the dilator first and try to put the sleeve, then it's not possible due to the tracking device. That's why I'm going to introduce both together, but I would like to explain you a little bit about the sleeve position. We always use the 30-degree beveled working sleeve, and there's an attachment, there's a handle like that. You can place the handle here like this. Some surgeons prefer like this, and usually we prefer in this position. This is very important because while you are inside the patient, you know the opening of the sleeve according to the placement of the handle. Always the handle shows me where is my tip or where is my opening of the sleeve. I prefer like this because later I will explain why. Okay, in this case, I would like to do it together with the dilator, otherwise I cannot place the sleeve. Okay, when I'm there, I remove it. Then the next step is starting with the endoscope. Okay, the reason I told you to place, okay, I will do it. The reason why I place the handle always like this, I put my finger here and keep the endoscope distance easily like that. Okay, now starting the operation like this. Always you will find bloody things in front of you. First of all, you can wait a little bit with the irrigation. You will stop small bleedings. And the next, you can use your radio frequency to stop the bleedings, the small bleedings, and clear your way. Of course, in this model, in the plastic model, the radio frequency is not working. And then I will use my ronger to clean all the tissues around. Okay.
So given in the case where you are outside of the foramen,
yes,
like,
I'm outside
right
of
now,
the foramen, yeah,
yes.
directly.
Do you hold the sleeve, or
Yes,
is your assistant
yeah, maybe
holding
you
it?
can focus a little bit. I always control the sleeve with my finger.
Okay, so it's yourself. You don't ask your assistant or somebody, or can this be also the case?
Yeah, always the question is coming, can we ask the assistants to do that? Of course, it is possible, but in this case, your assistant has to be very experienced with the full endoscopic technique just to do the maneuvers for you, yeah? My opinion,
to prevent some damage.
It's not very easy, yeah, to find this kind of assistance. Okay, now what we see. I'm outside of the foramen. Let me clean a little bit better to show you. Here directly in this model, also printed from a real case. I know that in this side, we are at the left side of the model. In this case, there is a foraminal herniation also, just in front of us, what we see here. Okay. And here in the, for the orientation, we are at the left side, as I told you. And this side is the caudal side, 3 o'clock, and 12 o'clock is the dorsal side, and the 6 o'clock is disc space, and the 9 o'clock is the cranial side. What I see here, okay, in the 3 o'clock, I can feel that this is the bone, yeah? And then this is the pedicle, the caudal pedicle here. And if I follow the caudal pedicle, then I see the facet joint and entrance to the spinal canal here. Directly, I can feel this space here, and this the herniation in the foramen. Later, I can cut it. And then to search the exiting nerve root, what we do usually, we rotate the opening of the sleeve to the cranial side, and also the endoscope, 25-degree endoscope to the cranial side. Then we can find the exiting nerve root, as you see here in the 9 o'clock, and usually you will find extraforaminal herniations here. As you see here, this is a real foraminal, this is a real stenotic case that you see you don't have enough space in the caudal side. As we talked at the beginning, we could drill that part with a manual drill under the fluoroscopic control, but I'm going to demonstrate you how we can do it under the fluoroscope, under the visual control. I'm going to use the tip control shaver. There's a button here. If I press this button, the tip is deflected, then I can easily reach the corners here. I will show you. Okay. Again, you see it's straight. When I press the button, the tip is going around and deflect, and I can easily reach the sides. Here I start drilling from the pedicle to the junction of the ascending facet here. Maybe I can wait a little bit, okay. By this way, I can see, and also at the same time, as you see, I rotated a little bit the opening of the cannula to the caudal side. By this way, I can protect the exiting nerve root. Okay, let's see what we do. Again, okay, we resect the part of the facet joint.
Yes, Guven. So you have here what kind of drill? It's a diamond drill.
Yeah, this is
yes,
a
and,
diamond drill. Diamond. The tip is diamond. Yeah.
And does it make you feel safer when you drill than a normal drill?
Sure, diamond drills are much safer than the other ones, and also the second advantage to using the diamond ones is you can also stop the bleedings from the bone with the diamond one. If you use a aggressive one, you can create a lot of bleeding that it's not easy to stop with the radiofrequency if they are coming from the bones. You see, I don't change any direction of the endoscope. Yeah, I just press the button and deflect the tip. Easily, I can resect the bones around. This is very important because if you use a straight shavers here, then to reach, for example, to the caudal side, you need to change the direction every time. If you do this maneuver, every time you hit the ganglion here at that point, or you can squeeze the exiting nerve root easily. That's why this is a really big advantage to use a deflectable shaver. Without changing, you can keep the direction like that, and without changing any direction of the sleeve and the system, you can easily reach the corners like that. This is the advantage. I think that's the really, really big advantage. Yeah.
So actually, everything you do, you see everything. Actually.
Yes, I see the bone here. I know that where is the exiting nerve root, where is the entrance of the spinal canal, this pedicle, facet joint. I do everything under my visual control. Yeah.
So your target given now is to resect all the bone required, or to leave something, or
no. Usually we prefer to do that to get better access to the spinal canal. Then it means that if you can resect a little bit anterior part of the facet joint, then it's enough. Yeah. Of course, there are a lot of discussions in the literature that if you can do the recess decompression by this way, my opinion, it's not possible, because at the end of we will see definitely the traversing nerve root by this way, but it doesn't mean that sufficiently we can decompress it, because to reach the posterior part of the to decompress the posterior side of the traversing nerve root, then almost you have to do the total facetectomy. Then the question is we are doing a minimally invasive surgery. Yeah. We have to keep the structures intact at the end. Okay, now I have bigger foramen here right in front of me.
And as we are focusing here, you know, the requirements from the Middle East, in particularly during this webcast given. So, and one of them is, of course, they are always asking for the local anesthesia possibility.
If it is,
what
of
you
course,
have done so far, you can do everything under local anesthesia, of course.
Yeah, as I said at the beginning of my presentation, you can do all transforaminal procedures under local anesthesia. It's possible, yeah, or with the sedation or with the general anesthesia. It's possible. But my opinion, it's not possible to do interlaminar approach with the transforaminal with the general anesthesia. Okay, also you can use your Kerrison ronger at the end to cut these parts a little bit. but it's not very easy. You have to be careful not to squeeze something or cut something like that. Okay, as you see, we drilled all the way, maybe a little bit from the ascending facet here. Okay, now I have better access to the spinal canal. As you see in this model directly, we see the herniation in the foramen, a little bit paramedian area. Here, what you see is the epidural fat tissue, which I cleaned, and also the part of the flavum ligament, which is located medial to the facet joint in the level. Okay, let's go into the herniation here, and now you see we resect all that part under our visual control. At that time, also we protect the exiting nerve root, which is located in the cranial side here. And in this case, as I told at the beginning of the presentation, you cannot drill anything, you cannot decompress anything from the cranial side of the foramen. But for example, if you want to resect that part, it's really easy to reach with the deflectable shaver. At the same time, I know where the root is, I protect the nerve root, and when I deflect the tip, easily I can resect the tip of the ascending facet here also, if you want to do decompression for the exiting nerve root. But imagine that you are doing under fluoroscopy, and it's impossible to put the drill here and drill it due to the exiting nerve root here.
So if our viewers, they want, again, maybe some reorientation, please, because it's not very evident for everybody, of course, the transforaminal approach. Can you please just...
I will do it. Okay, now we are at the left side of the model. Means that 3 o'clock is the caudal side. And I can feel the pedicle here. This is the pedicle. Already I drilled a little bit from it. And this side is the facet joint, the posterior part of the spine. And this side, the 9 o'clock, is the cranial side. And here in the 6 o'clock, you see the disc space. Then, of course, this is the straight up. If you are working straight, then we can also rotate our system and our endoscope inside the working sleeve. And to search the exiting nerve root, for example, we rotate the sleeve. I know this. The opening is now looking to the cranial side. I know this because of the handle position. Every time I get information from the handle, yeah, then the opening is looking to the cranial side, and at the same time, I rotate my endoscope. The endoscope, this endoscope is a 5-degree endoscope. Then I can easily see reach the axilla of the exiting nerve root, located here, and also definitely...
So this is your exiting nerve root here?
Yeah, this is exiting nerve root, and in most cases, the herniations are located here. You can do this approach. You can do the regular transforaminal approach, pull the system back, and rotate to the cranial side if you see enough space in the caudal side of the foramen. But sometimes, as we told, the exiting nerve root position could be changed due to the fragment, because the fragment could push the exiting nerve root somewhere here. Then you cannot do the regular operation. Then the option, you have to put your needle, insert your needle into the bone, this junction. It is the junction of pedicle to the ascending facet. Then you can start the operation like that, dissect all the tissues, and try to find the disc space. But in this case, you see my opening of the sleeve is looking through the caudal aspect. Means that I protect the exiting nerve root, and slightly I go to the cranial side and retract the root and see and try to reach the pathology directly here. Otherwise, you can easily hit the neural structure if you try to pass through the Campbell triangle. Okay, now you see the intraforaminal disc herniations, and then the next you can do like that. You can. I would like to show you another maneuver also here. The working channel is located eccentric, means that not in the center of the optic. Then when I put something, it comes in front of me. Yeah? Then I don't see what I'm doing like that. Then I keep the direction of the instrument and rotate the endoscope keep the direction of the system, and just rotate the endoscope inside the working sleeve. Then I see what I'm cutting. Then I cut the annulus or the PLL here. Then I reach the herniation, as you see here. Then the next step is removing the herniation. And in this case, the interforaminal herniations or paramedian herniations, you're going to work below the PLL. And then when you remove the PLL, if you see the free floating of the PLL, then it means that the compression has been done. Yeah, you don't need to see the traversing nerve root or something like that. But in this case, I would like to show you where the traversing nerve root. Okay, I don't want to lose too much time to resect that herniation. I think it's clear how to do that. Maybe I would like to give some time for the discussion. And then if you go above this and remove that fat tissue, here definitely you will see the traversing nerve root in front of you. It's here in the back. You see? The white tissue is there. I mean, this one is the traversing nerve root, and or the dura. Yes.
Even can you show us? You have just used different kind of instruments, yeah. Just to be clear for our viewers. So this is your electrode, yeah. That's clear.
Basically, for the transforaminal approach, we have the instrument of scissors that you can cut, okay. And this is the 2.5 millimeter ronger that you can grab something. And of course, we have different sizes here, like, for example, this one is the largest one, the 4 millimeter. You see how big it is, yeah? Then usually in the transforaminal approach, we don't prefer the big, large instruments, but it is, if you want to resect, sometimes you need to catch the strong fragments, like young patients, then it's really useful to have it in your hand. And what I can
you would recommend to use a rather small instrument.
Yeah, it is better because as you see here, the principle of the full endoscopic approach is based on seeing what you do. Yeah. And here like that, if you use 2.5 millimeter instruments and if you rotate your system, then you see what you are doing. Yeah. But if you are using, for example, the 4 millimeter instruments, you see, it blocks everything, yeah? The view, I mean. Of course, it is possible. If you are sure that you are not grabbing something, then you can use this one. Usually, we use the larger instruments inside of this space to clean more nucleus material. But around the neural structures, my recommendations always use the smaller instruments to see what you do. Okay.
Okay,
I think
thank you.
These are the steps for the bone resection. We have some time for the discussions also. If you have questions, please use the chat function of the YouTube, or later you can send us email education@RIWOspine.com. Okay.
Yes, thank you, Given. So far, the first question that I have here, coming in from on our email, is actually when I'm a beginner, or let's say I'm a beginner for foraminal bone resection. So I'm not an endoscopic beginner, of course, because this is something, as you said, that you would not recommend to somebody starting with endoscopy, but somebody who has a certain experience already in interlaminar and transforaminal approaches. And if I have done certain amount of cases, maybe you could say also more or less how many, and I'm now starting with foraminal bone resection, what should I do? Should I use the foraminoplasty set to do this under radiologic control, or should I do this under visual control as you did right now?
Yeah, it's Robert. It's not easy to answer this, yeah, because it depends on where to learn or which philosophy are you following. Yeah, I can share only my experience. In my daily practice, I don't use too much the radiological control because I don't feel very comfortable if I do resection under fluoroscopy blindly near the neural structures. That's why every time I prefer to use the tip control shaver if I want to do the bone resection. And then the easiest case to start that one, as I told you, you have to check the foraminal anatomy. Definitely, you need a space in the caudal side first, yeah? Then you can, by this way, if you have enough space at the caudal side, you can do the regular transforaminal approach. This is very easy, and pull back the system a little bit outside of the foramen, then you can see the anatomy better, easily. But if you don't see any free space in the caudal side of the foramen due to the herniation, and then you have to start in the junction at the caudal pedicle to the ascending facet. In this way, everything will be free. You will not stuck in the foramen, and you have to control the sleeve and the instruments. That needs a little bit experience. As I can see here,
yes, we have. Thank you, Gubin. Yes,
we have one
thank
question.
You, Gubin. Yeah.
Can
I? Yeah. Of course. Yeah, we have some questions now popping in, and thank you to the persons that are asking the question. So, just with regard to your reply, of course, we have also videos that shows to you the foraminoplasty resection. Yeah, so I will post them in the chat function for all of you who are interested to do this under radiologic control, of course. Yeah. And now, so going now to the question, so Khalid Ali is asking.
I can read it from here, yeah, Robert. I can take it.
Great.
Yeah. Okay, can I work without using the radiofrequency tool? I never recommend this. Yeah, in case if you have bleeding, then you need to stop it. Yeah, because during the full-endoscopic operations, usually the bleedings are not problem for the patient, but the small bleedings are blocking your visualization. Then you need to stop all kind of small bleedings. And my recommendation, it's not easy to do without radiofrequency. You can do this operation without something inside the set, but not the radiofrequency. And if the question is, in this case, we get this question several times, shall I use my regular bipolar, for example? I never recommend this because we need to use the high frequency because to protect the neural structures. If you use your bipolar, conventional bipolar, then you can easily damage the neural structures during the operation. Okay, what is the approach
if?
Yeah. Okay, the next.
Sorry, if I can also share my experience from the OR. So I had exactly this case as you described that we wanted. This was pretty much in the beginning. We wanted to do with a German surgeon. Absolutely, the surgery, the transforaminal surgery with their normal bipolar frequency. So we started doing the transforaminal case. We had, of course, a lot of bleeding, and we did not see anything at all. And the problem is at that step, we were not sure what is inside the whole blood. So if there's any, neurostructure, with the normal bipolar, we would have injured them. So we could not continue the surgery because it was too dangerous. And from that moment on, he said never again he will do that way. So the 4 megahertz radio frequency is pretty much mandatory.
Yeah, right. Okay, another question. What is the approach if extraforaminal L5-S1 disc? Definitely it will be extraforaminal approach. Yeah, you cannot reach the extraforaminal area with the interlaminar approach. Then you need to do transforaminal approach. But keep in your mind that reaching the extraforaminal area at the level L5-S1, it's not easy because all the spaces are very narrow. They are due to the transverse process, iliac crest, exiting nerve root, and the facet joint. Then you have to do oblique direction, and usually for the extraforaminal L5-S1, we start pure extraforaminal first. We place the needle at the caudal side of the needle junction of pedicle to the ascending facet. Then we start the operation under our visual control, dissect all the tissues, try to find the exiting nerve root and this space and the herniation there. But these are the most difficult operations of the transforaminal approach. Maybe you should keep it for the later. Okay, another question. Do we have another question? Okay, Professor Yusuf. In extraforaminal cases, do we need drilling? 99% we don't need because I can demonstrate it on the model again. Here, for the you need the drilling to reach the spinal canal. Yeah, but extraforaminal area, you are already outside of the foramen, and you don't need to reach resect the bony structures here. Okay, maybe. Again, like that, for the most common extraforaminal herniations are located in the cranial side, push the exiting nerve root outside to the posterior part, and then in this case you can stay outside. Even this foramen is narrow or not, I don't care about it, because if I rotate my system to the cranial side, I can easily reach the extraforaminal area like that. Then I will never have any problem with the narrow foramen. Narrow foramen always the problem. If you want to try to pass through this foramen with your instruments to reach the spinal canal, or if you choose the transforaminal approach for the caudal migrated herniations especially, then you need to do a resection definitely here too much to reach that, because there's a pedicle here that you cannot reach behind the pedicle in this direction. Okay, the solution, what I see in the discussions in all over the world, you can use banded or the flexible instruments to reach there, but again, it's a blind, yeah? You don't see what you are catching there. And okay, you see some part of the herniation there, you can catch it, but you have to pray that it's one piece, yeah? You cannot be sure that you left one piece in the caudal side, which can cause the symptoms after the operations. Yeah. Do we have?
Yes, and yeah, there is another question that I don't understand very well from Nesma Mahmoud.
Oblique craniocaudal or medial? Maybe it is about for the direction for the L5S1. Usually for the L5S1, there will be the iliac crest, and maybe can we switch to the Frederick? Can we switch to the yeah? Then usually, if there's an iliac crest, you can choose the direction like that. But again, the lateral lines. Now in this case for the L5S1, you have to take care about the iliac crest. If you choose really far lateral, then you can block with the iliac crest. Then you can choose more posterolateral approach here for the L5S1 level, and then you have to take care about the iliac crest not to hit, and you can choose the line like this oblique to the extraforaminal area. The questions, I think.
Okay, great. I think so far all questions were replied, given. So I would say thank you very much. Very informative again, and thank you for to the audience also for being here with us during our webcast. Another question from my side, maybe to the audience, if you know we have done many webcasts so far on many topics. If there's any particular topic that you would like us to focus on with our clinical manager and neurosurgeon, or with other guys, whatever you want to do, please, you can write it either right now in the chat function or on education@RIWOspine.com, and we would be very pleased to meet your demands and requests. I will now post the video for the foraminal bone resection under radiology control that you can watch on our YouTube channel, as many other videos, as you know. And we thank you again for joining. Thank you to Dr. Griffin and the whole team in our headquarters, and stay safe and goodbye.
Okay.